Okay, in this session we're going to cover drugs that are used to selectively target growth factor receptor signaling. So a quick overview of what we're going to talk about. We're going to talk about the concept of oncogene addiction. This is really important for targeted anti-cancer therapy. So oncogene addiction is where a cancer is effectively addicted to a specific growth factor or signaling intermediate, and that is the one thing that is driving that cancer's growth. If you can block that particular growth factor or signaling intermediate, then you should be able to block that cancer's growth. If the cancer is responding to multiple signals, then blocking one of them will not work and the tumour is not oncogene addicted. So we're going to go through basic growth factor signalling, and we're also going to go through all of the signaling intermediates, so the RAS, PI3 kinase, RAF, MAP kinase pathways, and we're going to look at the effect of a mutation in something like RAS, PI3 kinase, which is downstream of the growth factor receptor, and see how that impacts upon growth factor signaling inhibitors that are targeted to the receptor. And to cut a long story short, if these are activated, they will prevent an upstream growth factor receptor targeting mechanism. It will prevent that from working. We'll then go on to some targeted therapies which are aimed at designing drugs to specific mutations that only occur in the cancer cells. So a classic example of this is the BRAF V600E mutation that you get in about half of melanomas. So this is amino acid 600, which is used to be a valine, and following mutation, that valine has become a glutamic acid. That creates a version of BRAF which is constitutively switched on, and therefore signals, proliferative signals, irrespective of growth factors which are earlier than BRAF in the signaling cascade. Also, we've got the BCR-ABL translocation. This is the ABL oncogene, which is activated by translocation to the BCR gene, and there are drugs that specifically act upon this translocated form of BCR-ABL, and the main drug there is imatinib, and there are some drugs that are designed once you get imatinib resistance as well. So oncogene addiction, as I mentioned earlier, is where a cancer is addicted to the signaling of a specific growth factor receptor or signaling intermediate, and therefore the therapy that we give targets just that one signaling intermediate. So this could be BRAF mutations, which are targeted with a drug called vemurafenib, which we'll come on to later, the BCR-ABL, which I've just mentioned, which is targeted with imatinib. And this oncogene addiction is thought to be an Achilles heel for the cancer. It's the weak point of the cancer. So the key point about targeting cancers using oncogene addiction-based targeted therapies is that if the cancer is addicted to one oncogene, let's say HER2, you should only have to target the HER2 receptor to block that cancer's growth. So we have a whole range of anti-cancer therapies which are targeted to either growth factor receptors or signaling intermediates, which are oncogene addiction based. So the epidermal growth factor receptor, frequently overexpressed in lung and colon cancer, and we can target that with cetuximab, which is an antibody to the EGFR. I've mentioned Gleevec already. It's a BCR-ABL inhibitor used in chronic myeloid leukemia, and BRAF, where you get mutations particularly in melanoma, and we target that with vemurafenib. HER2, a bit like epidermal growth factor receptor, overexpressed in breast and colon, and for that the drug of choice is Herceptin or trastuzumab. There are other oncogenes which we think have oncogene addiction, particularly RAS, very frequently mutated in pancreatic, melanomas when they don't have BRAF mutations, and lung. And there is no approved drug yet. There is a new drug which is about to enter clinical trials, but there's no clinically available drug yet. I'll come on to uveal melanoma later on. Most uveal melanomas have got a mutation in GNAC or GNA11, roughly in the same place, but again, there's no actual clinically available drug yet. These targeted therapies tend to come under two main categories. And you can tell what sort of drug it is by the few letters at the end of the drug. So anything that ends in the word MAB is a monoclonal antibody, and monoclonal antibodies are large proteins typically used to block receptors on the cell surface of cells. In contrast, we have the NIBs. These are small molecule inhibitors, and they tend to work intracellularly, blocking particular domains of proteins. So, for example, one of the MABs, trastuzumab, it blocks the HER2 receptor. Cetuximab blocks epidermal growth factor receptor. Bevacizumab sequesters vascular endothelial growth factor. So all of these are all working extracellular to the cell because we're dealing with a large antibody that cannot get inside the cell. Whereas the NIBs, so erlotinib and gefitinib, they both block the tyrosine kinase domain of epidermal growth factor receptor. So that's intracellular, and it's a small molecule that can cross the plasma membrane and it can block that kinase domain. Similarly, sorafenib and sunitinib, those are both tyrosine kinase inhibitors of VEGFR-2, so they can act as anti-angiogenics. They also have some broad spectrum activity against all tyrosine kinase receptors. Similarly, vemurafenib has the word RAF in it. It's a RAF inhibitor, and it's got the word NIB in it. It's a small molecule inhibitor, so this blocks the mutant oncogenic RAF. And I've already mentioned imatinib. Again, it's a NIB. It blocks translocated ABL in chronic myeloid leukemia. So we tend to use these targeted therapies for personalised medicine, where we know that the cancers have a particular mutation that will make them susceptible to that particular drug. And this is not a new concept. We've been doing this for a long time with tamoxifen, which blocks estrogen receptor and progesterone receptor and is used for treatment for ER and PR positive breast cancers. We know that if the cancers are ER negative or PR negative, then you've got a poor prognosis and they will not respond to tamoxifen. So personalised medicine is not a new concept, it's becoming much more specific to specific cancers with a larger range of drugs. Also, we've been treating HER2 positive breast cancers for quite a long time with Herceptin. We only treat cancers which are HER2 overexpressing with Herceptin because the other cancers wouldn't respond to it. And we have a whole range of testing that we put in place, I'll explain later, where we perform either immunohistochemistry to look for HER2 overexpression, or we look for gene copy number of the HER2 oncogene by fluorescence in situ hybridization, and we'll discuss that later. So this is the generalized cell signaling pathway of proliferative growth factors. You can see you've got the various human epidermal growth factor receptor types. HER2 is in there, human epidermal growth factor is one of those, and they all signal in pretty much the same way. They are tyrosine kinase receptors, so they've got a tyrosine kinase domain. Remember, kinase refers to phosphorylation, so we get phosphorylation of this domain here upon ligand binding, and then we have a signal passed on down various different routes. This is very much an abbreviated route to drive survival, but we also have another pathway which passes through RAS, RAF, MEK, and other mitogen activated kinases, what we call the MAP kinase cascade, and the net effect of activating these receptors is passing the signal down through this cascade to increase cyclin D, which you've already heard is one of the prerequisites for getting cells out of G1 of the cell cycle. So binding here, passes signal down through here, increases cyclin D eventually. And this just shows where the various drugs bind to. So you can see the epidermal growth factor receptor here with cetuximab and panitumumab. They're antibodies which bind to the epidermal growth factor receptor and prevent either ligand binding or dimerization, which is crucial for signaling. Herceptin, also known as trastuzumab, that binds to the HER2 receptor. Both of these signal via RAS, RAF, MEK, and they work to drive proliferation. So blocking here or here will block eventually cyclin D expression and cell cycle progression. We've also got inhibitors that will block the tyrosine kinase domain of EGFR, so gefitinib and erlotinib, and the patinib, which can also block HER2. So we only give drugs like Herceptin if we know that the cancer is overexpressed in the HER2 receptor. So this is just the immunohistochemistry an interpretation for determining whether a cancer is HER2 positive or negative. And we see all of this brown staining. You can see this is a section of breast tissue, and you can see that the receptor, which is stained in brown, is expressed on the cell surface. That's where you'd expect to see a growth factor receptor. So this is very highly expressed. This would be a score of 3, whereas here we have either weaker expression or less extensive expression, and this would give a score of 2. So both of these would be classed, this would certainly be classed as positive, and this would be classed as positive, whereas an absence of staining and more cytoplasmic staining, but very weak, these two would both be classed as negative. This is 0, this is a score of 1. These cancers which score 2+, what we tend to do is back that up with a fluorescence in situ hybridization to find out if the gene is amplified. That is where you get multiple copies of the HER2 gene. So these definitely are eligible for Herceptin, whereas these we often check out by fluorescence in situ hybridization to see if there's a HER2 specific gene defect within these cancers, and if that's present we can give Herceptin. And this is the HER2 in situ hybridization, so we're looking for the gene copy number of the HER2 gene. The HER2 gene lives on chromosome 17, so if we use a DNA probe which recognises the HER2 gene, apply it to cells stuck to a microscope slide, denature the DNA, and allow that probe to bind. In this case it's a red label probe. In a normal cell you've got 2 copies of the HER2 gene and 2 copies of chromosome 17 centromere as an internal control. This is normal. Whereas in cancers which overexpress HER2, they often overexpress HER2 because they've got more copies of the gene. Here's a cancer with 3 copies of chromosome 17, not unusual, and 1, 2, 3, 4, 5, 6, 7, 8, 9, about 10 copies of the HER2 gene. So this is positive, and this is clearly very, very positive. Here's a slightly more complicated case. We've got 2 copies of chromosome 17. We've got apparently 2 signals for HER2, but this is caused by tandem duplication of the HER2 gene. This is a much bigger signal than here, so we might have got dozens of copies of the HER2 gene all back to back. We've got more copies of the gene, more mRNA, more protein, higher expression. So this would be classed as HER2 positive as well. We can do something similar for epidermal growth factor receptor copy number. So we get a more diverse variety of patterns for EGFR amplification. But as you can see, in all cases, we've got a few copies of, in this case, chromosome 7, which is where the EGFR gene is, and lots of copies of the EGFR gene itself. So these are clearly overexpressing, well, not overexpressing, but they are amplified for EGFR gene, which would lead to overexpression. So if we know that the cancer is selectively amplifying the EGFR gene or the HER2 gene, then we know that that cancer is likely to be utterly dependent upon that oncogene for its growth and survival. Therefore we can selectively target just that oncogene. So we don't have to just use the antibodies such as HER2 targeting Herceptin or EGFR targeting cetuximab. We can use the small molecule inhibitors which are fairly specific to epidermal growth factor receptor or vascular endothelial growth factor receptor or HER2. So we've got small molecule inhibitors that can be used in place of the large antibodies. The main problem with targeted therapies is they often don't work. And the reason they don't work is the cancers are not actually oncogene addicted. So the problem with HER2 and EGFR targeted therapies is we're assuming that because HER2 is overexpressed, it's oncogene addicted. Quite often that's not the case. If the cancer has also got downstream mutations in RAS or RAF or the MAP kinases, those mutations will render the HER2 antibody Herceptin and the EGFR antibody cetuximab, it will render those useless. Equally, some cancers can detect point mutations in the tyrosine kinase domain that are not blocked by the NIBs, such as erlotinib and gefitinib. So those mutations can make cancers resistant to the tyrosine kinase inhibitors, so that can stop those from working as well. But the main point here is if you've got any mutation downstream of the receptor that is activating, it means that there is no point in targeting that receptor specifically. So here's the signalling pathway again. If the receptor is overexpressed, it's sending signals down this route and down this route. However, if RAS is active, or RAF is active, or MEK is active, then there's no point in blocking here because that signal is still going to get through. And some of these NIB type drugs have been designed to specific mutated oncogenes. In this case, BRAF, which is a gene that is mutated in about half the melanomas, and when they're mutated, when BRAF's mutated, it's almost always the V600E mutation, which has allowed the creation of a drug called vemurafenib, which only recognises the oncogenic form of BRAF. So normally you've got your growth factor receptor activated, that passes on the signal to RAS, passes on the signal to RAF, MEK and ERK, and that causes normal regulated cell cycle progression. In the case of mutant BRAF, we don't need any of this growth factor signalling because BRAF is permanently switched on. That drives MEK, that drives ERK, and that drives eventually cyclin D expression and proliferation. In the case of vemurafenib, it binds specifically to the mutant BRAF V600E version, blocking this signalling pathway and causes cell cycle arrest and eventually death of those tumour cells. So this slide covers the problem of these downstream mutations, especially when we're targeting the growth factor receptor. So cetuximab, panitumumab, they both target epidermal growth factor overexpressing tumours, so we only give them to EGFR overexpressing tumours. So that's a bit of personalised medicine going on there. They were initially approved for colon and lung cancers, but only a minor population who were given these drugs responded. And the reason why is because the majority of cancers also had mutant K-Ras or something else. So although these cancers appear to be addicted to EGFR, they also had K-Ras mutation. You block EGFR, K-Ras still signals, so it's pointless blocking this receptor. So in 2009 the FDA overruled its previous approval and now said that unless you could show that tumours were free from K-Ras, you couldn't give this drug because it had no patient benefit. So now the current regime is to check that the cancers are EGFR positive, check that the K-Ras mutant negative, but also check that the BRAF and PI3 kinase is negative as well. So the situation now is if the EGFR positive and what we now call triple negative for K-Ras, BRAF and PI3 kinase, we find that most of these cancers respond to cetuximab, whereas previously less than 10% of cancers that are EGFR positive would respond to cetuximab, and this was all down to these downstream mutations preventing the blockade of EGFR being effective. So there's a big push now for screening for mutations in cancers to then decide which drugs will work and which drugs definitely will not work. So the problem with oncogene targeting, it targets just a single feature of that cancer, one overexpressed, one overactive gene. Things downstream of that gene can be switched on, in which case it's not oncogene addicted, in which case you don't give the drug. And another major problem with targeting a single feature of the cancer is that these drugs just don't work very well, and that's because cancers can evolve very quickly to get round targeted therapies. So all the cancer has to do is acquire a mutation downstream of where you are targeting, switch on that oncogene, and make the drug that you are giving utterly useless. And this is really well characterised for the BRAF inhibitor vemurafenib. If you give this to melanoma patients, their tumours will rapidly regress and the patients will appear tumour free. But whilst that is happening, rare tumour clones which had a mutation in the MEK gene, which is downstream of RAF, that has become activated. It's become activated because cancers have a very high mutation rate, and eventually the cell's going to pick up a mutation in MEK that just happens to be constitutively switched on. And the selective pressures of killing off all the cells that are RAF mutant, you kill off the bulk of the tumour, you leave a few rare cells behind which are MEK mutant, and they continue to grow. So whilst the bulk of the tumour is dying back, a minority of cells are starting to grow back which are MEK mutant, and they're completely resistant to vemurafenib. And this is the major issue, in that if a patient's got dozens of tumours, you can kill off apparently kill off the bulk of all of those tumours, but every single one of them will grow back, typically with a mutation in MEK1 or a related gene. So in summary, many novel therapies are targeted at cancer cells with very specific mutations and are given in a sort of targeted therapy and stratified cancer medicine strategy where the cancer is treated based on what mutations it has. We can easily screen for HER2 overexpression and put those patients onto, let's say, Herceptin, but if the tyrosine kinase domain is mutated as well, that drug won't work. If something downstream of that receptor is activated, that drug will not work. If you're doing something very specific like targeting vemurafenib, you can target that, but if that cancer's got a very high mutation rate, something downstream of vemurafenib will inevitably become mutated and activated, and that will bypass the blockade of BRAF by vemurafenib, and the patient will relapse. And in most cases treated with vemurafenib, you get a few months of really good treatment and then rapid regrowth of the tumour, and then the tumour effectively becomes untreatable. So to summarise, targeting tumours on the basis of oncogene addiction only works if they're addicted to a single oncogene, which is sometimes the case. It can be targeted, which is sometimes the case, and that tumours do not find some way around it. And any cancer that's got a very high mutation rate, such as melanoma, inevitably finds a way around a targeted therapy. We know that melanomas are have a very high mutation rate, sometimes due to ApoBec, which we'll cover in a different lecture. But treatment with drugs like vemurafenib are certainly not a cure. They will knock back the tumour for a period of months, maybe a little bit longer, but inevitably mutations arise and the patients relapse from that therapy.